I think this is probably a good time for us to pivot into chronic graft-versus-host disease. And I'm going to ask Dan to present our case of chronic GVHD for discussion.
So the third case is on moderately severe chronic GVHD. And it is about a 35-year-old woman who had an unrelated donor transplant for AML with myeloablative conditioning regimen, BUSI, and had tacrolimus plus methotrexate as GVHD prophylaxis. A month post allogeneic transplant, she developed grade 2 acute GVHD of the skin. She was treated with steroids. And 6 months after allogeneic transplant, she presented with vaginal dryness, which was treated with topical estrogen by her gynecologist. 11 months after allogeneic transplant, dry eyes, foreign body sensation added to the picture, and she was treated with, again, topical agents by the ophthalmologist, and actually the symptoms persisted through this. 12 months after allogeneic transplant, she presented with muscle and joint pain, limiting daily exercise routine, and actually she was given prednisone and responded to it. 17 months after allogeneic transplant, she started developing sclerodermatous changes with decreased range of motion in some of her joints, and decrease FEV1 and DLCO on pulmonary function tests, but no dyspnea. So that's back to you, right, Corey?
Yeah, so a lot to unpack here. So a very complex case. We can talk about how we stage and grade this chronic graft-versus-host disease. We'll go through your treatment options for this patient, the role of steroids, the role of second-line agents, the role of clinical trials, and maybe you could talk to us first about what staging system you use for chronic GVHD and how this patient fits in.